I'll be talking on mainly diagnosis and management because all of you know the etiology of ectopic pregnancy, the causes, this and that. I'm not going to touch upon that. This ectopic pregnancy, tubal is the commonest, 96%. In fact, my daughter actually gave me this new classification and I happened to see this. Uterine ectopic. What do you mean by uterine ectopic? Interstitial, that is cornual or rudimentary horn ectopic. There is something called intramural. I also heard it very recently, which is extremely rare, less than 50 reported. Maybe in the wall, it never comes into the cavity, it grows there only. I have not seen this or not heard of this. Cervical, again, the toughest one to treat at least. Then the scar ectopic, we have seen this in plenty. So these all come under uterine ectopic. Then we have ovarian ectopic. There are specific criteria for this. I'm going to talk in detail about that. And there is abdominal ectopic. I have seen only one abdominal pregnancy, which usually is out of an ectopic pregnancy. Then it gets anchored there. This was way back in 1987 when I joined as a postgraduate. Our HOD that time, Dr. Nalini, she just put a hand on the abdomen of the patient and like a miraculous diagnosis, she said it's an abdominal pregnancy. That time there was no ultrasound actually. We had to take her to the X-ray room and she was very bold. She said there's no ectopic, there's no pregnancy inside the uterus. She put a uterine sound and took an X-ray. The baby was inside the abdomen. And finally, heterotropic pregnancy, which means there is an intrauterine pregnancy as well as there is an ectopic pregnancy. So this is the classification of ectopic pregnancy. How do you diagnose? It's a combination of serum quantitative HCG and transvaginal ultrasonography findings. Gone are the days when we used to do the Culdocentesis, this and that. I'm going to talk more about that later, but currently it's either serum HCG or transvaginal sonography. The clinical presentation, vaginal bleeding and or abdominal pain. Abdominal pain happens once the uterine, the tubes start stretching. And of course, when it ruptures, the pain is the most. Vaginal bleeding is always common. The reason for that is the decidua is not well supported by the available progesterone. You will soon see this. That also could be a diagnostic point for ectopic pregnancy. Most of the time, it can be asymptomatic. The day it is diagnosed, probably it is ruptured. That is the tragedy. It's almost like searching for a black cat in the pitch darkness. This is the favorite sentence that my teacher, Dr. Pratap Kumar, used to say. So only when you flash light, then can you see the iris of the cat. Consider ectopic. That means you must have an extra suspicion, intuition rather, for ectopic pregnancy. Any patient of reproductive age with vaginal bleeding and or abdominal pain, which I told you, these are the two main symptoms, with following characteristics. What are they? Pregnant, but does not have a confirmed intrauterine pregnancy. What in an article I found it as slightly pregnant in the layman terminology. She is pregnant as per the urine pregnancy test or even maybe beta HCG, but on ultrasound, you can't see an intrauterine pregnancy. Suspect ectopic pregnancy. Pregnant and conceived with IVF. Chances of ectopic pregnancy is more. There are many reasons for this. Maybe a high, the embryo transfer, sometimes even the sucking effect from the cornua, there can be ectopic pregnancy. Or if you transfer too many embryos, also one of them may just slip into the tubes. So it is possible to have ectopic pregnancy in IVF. Pregnancy status uncertain, particularly if amenorrhea of more than 4 weeks preceded the current vaginal bleeding. Sometimes the patients come and tell us, I had my LMP just 4 weeks ago or something like that. So there is no possibility of a pregnancy at all. That is ectopic pregnancy. Sometimes there may not be any amenorrhea at all. She may not be married. She may not be having intercourse. She is sterilized. Whatever it is, it can be ectopic pregnancy. In fact, I remember teaching from my professors, which I passed on to my students. In a reproductive age group, if a lady comes with pain abdomen, with or without bleeding, or vaginal bleeding, with or without pain abdomen, please suspect ectopic pregnancy in the back of your mind. Or the other terminology is, it is ectopic pregnancy unless proved otherwise. Nothing wrong in that, no harm in that. You don't have to tell the patient that you are pregnant, because sometimes they may get offended, especially if she's unmarried, especially if she has undergone sterilization, especially if she's very, very young. I have seen a patient, in fact, I only have operated on her. We thought it was a case of ovarian cyst, twisted ovarian cyst, 12-year-old girl. We did a laparoscopy for the ovarian cyst. There was an ovarian cyst, no doubt in that. It was twisted and it was all, there was hemorrhage in that. But behind that, in the tube, there was ectopic also. So that means a 12-year-old girl could become pregnant. Afterwards, she revealed the truth. She was actually having a sexual contact with another boy. She was from the stonecutters, community there at the construction site. So anything and everything can be ectopic. There are other stories. A patient was brought to ICU. She was admitted into medicine. She was very, very pale, and the abdomen was full of blood. They thought of everything on earth, including aortic rupture, but they never thought of ectopic pregnancy. By the time OBG consultation was given, they said it is ectopic pregnancy. And from that day onwards in Manipal, in ICU, the rule is, if a lady comes, especially in the shock or any undiagnosed situation, what you must minimum do is a beta HCG. You may not have to offend the lady by saying you could be pregnant. You don't have to say, I am going to do a pregnancy test. Simply send serum beta HCG. It could be ectopic pregnancy. More things. Presenting with hemodynamic instability and acute abdomen. That's what I just now told you. That is not explained by another diagnosis. 18% of the cases would be ectopic pregnancies. So I told it as shock, but here the wording is hemodynamic instability and acute abdomen. It could be ectopic pregnancy. Do a beta HCG. Beware, the early pregnancy symptoms may be less common in them. They may not have typical nausea or vomiting. They may not have morning sickness. They may not have all presumptive symptoms of pregnancy, because progesterone, estradiol, and HCG levels may be lower than in normal pregnancy. That's exactly why they won't have typical symptoms. I told you most of them could be asymptomatic. This is the reason. Also, the bleeding is because the lower estrogen and progesterone will not support the decidua that has come up, and that will be shed. And that's why it is ectopic pregnancy. At presentation, it could be unruptured or it could be ruptured in 18% of the cases. It can result in life-threatening intra-abdominal hemorrhage. I always tell, you can diagnose ectopic not even HCG or ultrasound. Just looking at the conjunctiva, if it is papery pale, it is nothing but ruptured ectopic pregnancy in a lady, of course, and that could be life-threatening. Ruptured ectopic, there could be sudden, severe and persistent abdominal pain, sudden pain, sudden giving up of the tubes, and hemoperitoneum collection in the peritoneum will give persistent abdominal pain. Symptoms or signs suggestive of hemodynamic compromise. Obviously, when there is a lot of bleeding in the peritoneum, there will be hemodynamic compromise. Example, feeling faint, hypotension, tachycardia. Shoulder pain due to diaphragmatic irritation. This is called referred pain, what we all sometimes see in cases of pneumoperitoneum, that is caused, artificial pneumoperitoneum that we cause because of diagnostic laparoscopy. And if you don't remove all the air, there can be shoulder pain. Urge to defecate, because the collection in the pouch of Douglas may be pressing on the rectum and there may be urge to defecate. Eventually, hypotension and shock. So we should not actually wait till such level. Per abdomen, often unremarkable, or there could be lower abdominal tenderness initially, but once there is a lot of blood inside, you will feel the free fluid in the peritoneal cavity. With significant bleeding, there can be diffuse distension, localized and or rebound tenderness. What's the differential diagnosis? Physiologically, it could be implantation bleeding. That is a misnomer again. What I said is the decidua is shed because of lack of support from estrogen, progesterone, and even HCG. Spontaneous abortion can mimic ectopic pregnancy in the initial stages when there is only pain, abdomen, and bleeding, and patient doesn't have any syncopal attack. You don't suspect anything. It could just be looking like spontaneous abortion. Cervical, vaginal, or uterine pathology, for example, cervical polyp, again, bleeding and pain abdomen. Subchorionic hematoma, there could be pain abdomen and bleeding, again, something like threatened abortion. Gestational trophoblastic disease, high HCG will reveal the truth. Now, I always used to teach undergraduates, there are only 3 problems in first trimester. One is abortion, one or other type. It could be threatened abortion, inevitable abortion, incomplete abortion, complete abortion, missed abortion, whatever it is. The second one is gestational trophoblastic disease. Of course, the third one is ectopic pregnancy, but I would rather put it as number 1, maybe in the back of your mind. The differential diagnosis in general for pain abdomen, urinary tract infection. If it is not pregnancy related issues like what I showed in the previous slide, it could be urinary tract infection. Kidney stones, there can be severe colic. There can be ureteric stones. Diverticulitis, appendicitis will mimic. After all, you will have pain abdomen, nausea, vomiting, and if it is on the right side, you may think that it is right-sided ectopic pregnancy. Ovarian neoplasms, especially when they undergo torsion or rupture or infected. Leiomyomas and round ligament pain. Sometimes the round ligament are stretched and that can give rise to pain, one-sided, especially if there are one-sided leiomyomas. But not typically accompanied by vaginal bleeding. None of them. Urinary tract infections, kidney stones, diverticulitis, appendicitis, ovarian neoplasms, and leiomyomas, they are not typically accompanied by vaginal bleeding. Of course, leiomyomas will give rise to menorrhagia, but that is coinciding with the menstrual cycle. Now I come to all important, then heavy changes are there in the management of ectopic pregnancy. As far as the management is concerned, the diagnostic evaluation consists of first and foremost confirmation of pregnancy. I was telling you that a minimum that you can do is a beta HCG. You don't have to tell the patient that I'm going to do a pregnancy test. Patient may get offended sometimes if she is not married, or if she was sterilized, or if she was, not anticipating to become pregnant at that time. Evaluate the patient for hemodynamic stability or instability. That's very important. If the patient is hemodynamically unstable, you have to fast track the treatment. You have to straight away think of doing probably a surgery, either laparoscopic or laparotomy. Only when the patient is hemodynamically stable will you think of other things. The site of pregnancy becomes very important because 40% of pregnancy of unknown location will be ectopic. This has to be kept in mind. Serial transvaginal sonography and serial HCG, what we call HCG doubling time, is very, very important in the diagnostic evaluation of ectopic pregnancy, especially when you don't see intrauterine pregnancy on ultrasound. Serum progesterone, I'm going to talk little detail about it in the subsequent slides. The problem with serum progesterone estimation is that definition of low progesterone is unclear. The usual lab tests, CBC, blood group and type, because you require a lot of blood and blood products, and coagulation profile. Sometimes the patient would have slipped into DIC because of hemorrhage. Pre-treatment LFT. That means if you are planning to give medical line of management with methotrexate, LFT is a must. Now, let us take up one by one scenario. Patient is hemodynamically stable. How are we supposed to proceed? First step, history, very important. 50% may not have any high risk factor. This may be their first pregnancy. They have not had endometriosis. They have not had any surgeries on the tube. There was no PID. There was no nothing. No ectopics in the past. Yet there could be an ectopic in the first pregnancy. So history is very important. Physical examination, you have to do PV gently because sometimes you may cause rupture of the ectopic if it is already grown to a point of rupture. Slightest provocation can give rise to rupture of ectopic. What you can definitely elicit is cervical motion tenderness. Step 2, HCG, that to serial HCG, especially if you cannot see a sac. Transvaginal sonography is good, but its sensitivity is only 10.9%. I have seen patients being overdiagnosed and underdiagnosed with TVS, but its specificity is 95.2% at HCG more than 2000 milli-international units per ml. That means once the HCG crosses this level, you have to see an intrauterine gestational sac. If you don't see, that means it is ectopic pregnancy and its specificity becomes 95.2%. How do you diagnose? As I said, there should be a high index of suspicion to diagnose ectopic pregnancy. Remember that black cat in pitch darkness. Ectopic is suspected in a pregnant patient with no evidence of intrauterine pregnancy on TBS and any of the following. Number 1, visualization of a complex, inhomogeneous, extra-ovarian adnexal mass. In 89% of the cases, this will be seen. An extra-ovarian adnexal mass containing an empty gestational sac, that's a tubal ring, what we call, is definitely a better sign than simple adnexal mass, because sometimes a simple adnexal mass can be confused for, let's say, some PID there or some tubo-ovarian abscess or mass of old ectopic or things like that. But if you see an empty gestational sac, that is definitely better. Intraperitoneal bleeding can be seen sometimes, even though there is no big rupture giving rise to big hemoperitoneum. There may be small leak of blood, maybe sometimes through the femoral end as well. So that would be again in favor of ectopic pregnancy. What more? Abnormal rise of HCG in 48 hours. Now here comes the big change from the old thinking. I remember very well teaching the students that whenever you don't see an intrauterine gestational sac, we diagnose pregnancy of unknown location. Thereafter, we do HCG every 48 hours. And if there is a rise of 66%, or if there is a fall of 15%, then in between is the ectopic range. That is the old teaching. Now, what do we say now? less than 35% rise is in favor of ectopic pregnancy. Of course, the NICE guidelines still maintain 63%. Anyway, I'm going to talk in detail in the subsequent slides. The expected rise is dependent on initial HCG level. So 35, 63, 66, all may be right, all may be wrong when you see the next part of the slide. If the starting beta HCG was less than 1500, expected rise is 49%. That means there is still scope for rise. If the starting beta HCG is 1500 to 3000, then the expected rise is 40%. But if it has already reached and it is more than 3000 millinternational units per ml, you don't expect more rise because it is now time for the ectopic to rupture maybe. It can't produce more than that. So the rise expected is only 33%. I think the 35 figure has come somewhere as an average of this. So now we don't wait for 66% increase. If the rise is not more than 35% in 48 hours, you start suspecting ectopic pregnancy. I hope I'm clear. Confirmation. Visualization of an extrauterine gestational sac with a yolk sac or embryo is much better. If you see a sac, it's okay, but it's not enough. If you see a yolk sac or if you see an embryo, even without a heartbeat, nothing like that. That is confirmation of ectopic. If you see a heartbeat, then that's the final proof. A positive HCG and no products of conception on uterine aspiration with subsequent rising or plateauing of HCG is again a confirmation. That means you are sure that there's nothing in the uterus now. Why should the HCG rise? That is ectopic pregnancy. That's the one which is still releasing HCG. But this uterine aspiration as a diagnostic tool itself is debatable. I'm going to talk about that in the next slide. Visualization at surgery. Of course, we don't do surgery to diagnose ectopic pregnancy. That's very, very obvious. We may be doing a laparoscopy or even a laparotomy when you are almost sure, pretty sure about ectopic pregnancy, and it is on the verge of rupture. Maybe you want to do something with that, then only you do surgery. But whenever you did that, a histologic confirmation following resection of ectopic pregnancy is like proof of pudding. That's the ultimate. Pathologists are the ultimate diagnosticians. So, but we don't have to wait till that. Now I talk about this discriminatory zone. There are different numbers given in different textbooks. So let me clarify all of them today. When it is 1500, 80% of the time, you should be able to see an intrauterine gestational sac. That's why many textbooks give 1500 as the discriminatory zone. When you see 2000 level, 91% of the time there will be intrauterine pregnancy. When the level is 3510, 99% of the time you should be able to see a gestational sac inside the uterus. But the question is, should I wait till 3510? What if it was an ectopic pregnancy? It would rupture sometimes by that time. That's exactly why setting discriminatory zone at 3510, though increases the ability to diagnose a live intrauterine pregnancy on TVS, but it also increases the risk of delaying a diagnosis of an ectopic pregnancy. And if you are unlucky, if the patient is unlucky, she would rupture and there will be hemoperitomy. So whatever it is, you must know these things. When a question is asked in the exam, there is no single answer for any question. So here is the reason for you to give all the answers. So 1,500, 80% of the time you can see, 3,510, 99% of the time you can see. But you have to go in a case based on other findings and take a decision. Discriminatory zone is higher for TAS. Anyway, nobody does TAS to diagnose ectopic pregnancy nowadays. It is very high, 6,500 milli-international units per ml. Progesterone levels, I promised to talk about this. For bleeding or pain and an inconclusive TVS, progesterone less than 3.2 to 6 nanograms had a sensitivity of 75% and a specificity of 98%. That's the lower limit. For patients with bleeding or pain alone without any TVS findings, anything less than 10 nanograms had a sensitivity of 67% and a specificity of 96%. All said and done, the sensitivity and specificity of a low serum progesterone concentration for predicting a non-viable pregnancy in spontaneously pregnant patients are different from those who have undergone controlled ovarian hyperstimulation for IVF or IUI. Obviously, in a natural cycle, there is only one ova that is released, and there will be one corpus luteum, and that will produce only so much of progesterone. Whereas when you have done superovulation or a controlled ovarian hyperstimulation for an IVF or an IUI, imagine there will be more than one corpus luteum bombarding with progesterones. So you will get a different value. That is the meaning of this particular slide. I hope you understood. Now, uterine aspiration, again, I told you it is controversial, debatable. In a couple of slides, I will explain that. Curettage or aspiration as a diagnostic tool is limited by potential for disruption of a viable pregnancy. Isn't it commonsensical? By chance, if there was a viable pregnancy in the uterus, you are unnecessarily disturbing it. Even if it is heterotrophic pregnancy, it is not worth it, because ectopic pregnancy is not going to be anyway viable for us. It's going to go for either methotrexate or for a surgery. So many people believe that uterine aspiration is not a diagnostic tool. Only on patients with both an HCG concentration below the discriminatory zone and a low doubling rate, where you are almost sure of an ectopic pregnancy diagnosis, probably it can be done. Approximately 30% of these patients have non-viable intrauterine pregnancy, and the remainder will have an ectopic pregnancy, which means suppose there was an amenorrhea and you didn't see an intrauterine gestational sac, you suspected ectopic pregnancy, and you did the beta HCG doubling time, not very sure, not very clear. So many people believed or still believe that let at least do a uterine aspiration. In fact, one of the students, undergraduate students, asked me this innocently. Sir, why don't we do a aspiration and send it for histopathology? If there is no pregnancy in the uterus, we are 100% sure that it is ectopic pregnancy, but not always 100%. See this percentage. 30% of those patients will have a non-viable pregnancy. Remainder will have an ectopic pregnancy. So you cannot use aspiration as a diagnostic tool. You diagnose ectopic pregnancy on its own merit using beta HCG doubling time as well as TVS. That is the meaning of this. Sensitivity of curettage in finding chorionic villi is only 70% and PIPL is 30 to 60%. Even there also, you will not be very sure about the intrauterine pregnancy among those 30% also. The chorionic villi is seen only in 70%. So 70% of 30%. Uterine aspiration, many believe it is more practical and less invasive to continue observation or administer one dose methotrexate than to perform aspiration. Many people think that what is there? I'll just do an aspiration. It is better than giving 1 dose methotrexate or just simply waiting and sitting on a bomb. The side effects of 1 dose methotrexate are negligible. That is one argument. Aspiration carries a risk of intrauterine formation, opposite argument. Whatever it is, many people feel there was no significant benefit of one approach over the other, that is aspiration or no aspiration before methotrexate. If you have decided to give methotrexate, why aspirate? And just see, because methotrexate will kill the pregnancy, whether it is in the ectopic region or in the intrauterine region, both ways. Of course, if the patient has got indefinite bleeding from the uterus, then aspiration has a role. That is my final conclusion. Culdocentesis. I think yesterday I stopped my class here, but let me talk about that. Historically, culdocentesis was used to detect blood in the posterior cul-de-sac. It was a really, really tough time when I was a PG. Poking the pouch of Douglas there, and you get some bleeding. You are not sure whether it's a bleeding because of ectopic rupture or whether it is because of your poke itself, and it was very cumbersome. This finding can be easily demonstrated with TVS nowadays, so don't have to do culdocentesis for this purpose. Blood in cul-de-sac may also be the result of a ruptured ovarian cyst. Remember, I talked about the girl who actually had a twisted ovarian cyst, which masked the ectopic pregnancy behind it in the ultrasound. Only when I did a laparoscopy, I realized that there was an ectopic as well. Hence, a culdocentesis positive for blood is non-diagnostic, not used anymore, banned. So I'll now come to, after step 1, where history and examination, step 2, TVS and HCG. Now step 3 is follow-up testing. In other words, you can also write this as an answer for how do you follow up a case of pregnancy of unknown location. PUL means pregnancy of unknown location. Serial HCG every 48 to 72 hours, preferably 48 hours. A rise in HCG of equal to or more than 35%, not 66% anymore, happens in normal early intrauterine pregnancy every 2 days. 99% of cases showed this, with a sensitivity of 92%, specificity of 94%. So remove that 66% from your mind, register 35% in your minds. Plotting or decrease of HCG by 15%, this is unchanged. Most consistent with a failed pregnancy. For example, I'll give an easy mathematical example. Suppose at 0 hour today, when the patient came, it was 1000. You repeat after 48 hours. It should increase by 35%, means it should become more than 1350. Then you can say that it is going towards intrauterine pregnancy, that value. Or if it is less than 850, you can say whether it is intrauterine or extrauterine, it is failing pregnancy, nothing to worry. But if there is a suboptimal increase, that is less than 35%, suboptimal decrease, that means less than 15%, that is in the range of ectopic pregnancy. I hope I'm clear. Manipal PGs, I used to teach earlier that 66%, now register it as 35%. The other one doesn't change. Natural history of ectopic pregnancy. If left untreated, an ectopic pregnancy in fallopian tube can progress to a tubal abortion. Still, there will be some amount of bleeding in the pouch of Douglas, but it is not as violent as ruptured ectopic. Expulsion through fimbria can occur. This can be followed by either a resorption of the tissue altogether. The peritoneum has such a tremendous capacity to swallow and digest everything that is thrown into it. Reimplantation of trophoblast in the abdominal cavity, that is abdominal pregnancy, or on the ovary and ovarian pregnancy. I told you yesterday about the case which was diagnosed by Dr. Nalini. That's a secondary abdominal pregnancy. Maybe this was the way it happened. occasionally may lead to surgical intervention. So if it becomes big one there, and then you may have to do a laparoscopy and suck out all the blood that is there. The other possibility is a tubal rupture, as I said, major cause of maternal mortality in first trimester. Very, very rarely, if the patient is lucky, doctor is lucky, it will regress spontaneously, but this is highly unpredictable situation. I'll talk about ovarian ectopic now, which can be a short note. 1 in 2,100 or 1 in 60,000 pregnancies, and it accounts for 1 to 3% of ectopic pregnancies. Diagnosis is typically made at the time of surgery. Nobody will suspect ovarian ectopic just based on ultrasound, unless your eyes are very sharp and the ultrasound resolution is so good that you can clearly see the tube and you see the ectopic sac inside the ovary, beautifully surrounded by the follicles, this and that. Strict histopathologic criteria are used to distinguish ovarian pregnancies from those originating in the fallopian tube. So pathologists will tell us whether it is of ovarian origin because they will see other tissues of the ovary in and around. The exact diagnosis is not clinically important since these pregnancies are usually treated by surgical excision. Methotrexate won't help here. If it is an ovarian ectopic, probably they require surgical excision. So it doesn't matter. It's just an academic debate between the PGs, between the faculty before they do a laparoscopy. Methotrexate has been successful in case reports only. 1 or 2 case reports are there. I mean, I can't say blanketly it is not at all useful, but by and large, it is not useful. It is not used at least. So the Spielberg criteria for ovarian ectopic is a standard question asked in the exam. So that's why I'm putting up this slide. The fallopian tube on the ipsilateral side must be intact. The fetal sac must be intra-ovarian. The ovary must be connected to the uterus by ovarian ligament. See, so it's all sounds silly, but it is very important. Ovary, of course, is connected to the uterus by ovarian ligament. But why this statement comes is that you should establish that it is ovary. Ovarian tissue must be located in the sac wall. That's how the pathologist will ultimately say in the sac wall, they see some ovarian tissue. So these are the 4 criteria for diagnosing ovarian ectopic. Now I come to the other one is interstitial ectopic, also called cornual pregnancy, originally referred only to those implanted in either the horn of a bicornate or a didelphys uterus or a rudimentary horn of a unicornate uterus or in one side of a septated uterus. But now, even if it's a normal uterus, if it is in one cornua, we call it cornual pregnancy. It is almost interstitial because some part of the tube is entering into the uterus. That is why. Accounts for, again, 1 to 3% like ovarian pregnancy and difficult to distinguish from eccentrically positioned intrauterine pregnancy. Sometimes pregnancy can be at the corner, especially in IVF cases. Usually presents later in gestation because they can grow for some extent. They are well within the uterine, some musculature. 8 to 10 weeks it can go up to, with rupture occurring approximately in 20 to 50% of the cases, less than 12 weeks. So rupture occurs usually late. Only in 20 to 50% it occurs before 12 weeks. In all other cases, rupture occurs much later. But by that time, of course, you would have diagnosed and you would do whatever is needed to be done. Delay in diagnosis, average 4 days. Suppose you diagnose a tubal ectopic, proper tubal ectopic. Today, the cornual ectopic is diagnosed 4 days later. That's the delay. Screening of an asymptomatic patient is very, very important. Routine prenatal care does not include serial measurement of HCG or an early TVS. So don't say every pregnancy I want to do serial HCG because yesterday Dr. Muralidhar said every lady with a pain abdomen is ectopic pregnancy unless proved otherwise. This doesn't make a case for doing a serial beta HCG if you have done a pregnancy test. Of course, if the patient is symptomatic, let's say pain abdomen or vaginal bleeding or in shock or hemodynamically unstable, then you suspect ectopic pregnancy. That is different. But a routine prenatal care does not include serial measurements of HCG or early TVS. The exceptions to this are patients at high risk for an ectopic. Yes. IVF pregnancy, I told you this yesterday. Pregnancy after reconstructive surgery of fallopian tube, obviously. Prior history of ectopic pregnancy, these are the cases you may do serial beta HCG or ultrasound. The use of same clinical protocol as for the diagnosis of ectopic pregnancy in a hemodynamically stable patient. So that's the same thing you do. That is once in 48 hours you do beta HCG. Undesired pregnancy. Suppose the patient says, whatever it is, ectopic or intrauterine, this pregnancy I don't want. What to do? In a patient with pregnancy of unknown location and in whom pregnancy is undesired, expedited active management can be offered. Anyway, she doesn't want the pregnancy. No, why wait? Whether it is intrauterine or extrauterine, she doesn't want this pregnancy. So what is that expedited management? Diagnostic uterine aspiration. Now here, aspiration makes sense. With laparoscopy, if an adnexal mass is present, and or methotrexate. So all the three you can do. If the big adnexal mass is there, you go for laparoscopy. Aspiration also done. If by chance 30% of the cases can have intrauterine pregnancy, isn't it? And suppose you feel that there is no mass, you can manage with methotrexate. It may reduce the number of follow-up tests. That's the reason. Otherwise, every 48 hours, if you have to do beta HCG, when she actually doesn't want any pregnancy, intrauterine or extrauterine pregnancy, why waste time? That's the meaning of this particular slide. COVID-19 and ectopic studies suggest that rate of ruptured ectopic pregnancy increased during COVID-19, maybe because delay in the diagnosis of ectopic pregnancy. Obviously, patients also went late. Reduced access to routine prenatal visits and first trimester TVS. Yes, it's the same meaning. Patients' reluctance to obtain medical care during the pandemic. Yes, all the three. Choosing a treatment now. The three approaches to the management of ectopic pregnancy are surgery, that is salpingostomy or salpingostomy. Nowadays, we don't do salpingostomy much because that will increase the risk of ectopic pregnancy in the next pregnancy as well. Many prefer salpingectomy. Methotrexate for a conservation of the tube. And finally, expectant management. So what is the Cochrane review between methotrexate and surgery? Treatment with methotrexate has comparable efficacy to surgery. For the first time, maybe Cochrane is coming out with a clear-cut conclusion. Not first time, but very rarely they give a clear-cut conclusion like this. And results in similar fertility outcome. Good. That means methotrexate is definitely a valid treatment. Methotrexate is preferred when patient is hemodynamically stable, HCG concentration is less than 5,000, no fetal cardiac activity detected on TVS, ectopic mass is less than 3 to 4 centimeters. Patients are willing, this is very important, and able to comply with post-treatment follow-up and have access to emergency medical services within a reasonable time frame in case of ruptured fallopian tube. All words are important. Willing, able to comply, have access. These three words are important. I remember most of our patients, the HCG will be lurking for nearly 1 month, sometimes 6 weeks, and they are all worried why HCG is not coming down. So we have to sometimes give additional methotrexate or counsel them properly. Methotrexate is contraindicated and surgery is recommended. Patient is hemodynamically unstable. Heterotropic pregnancy with coexisting viable intrauterine pregnancy. So there you cannot do this because it will kill the intrauterine pregnancy. Signs and symptoms of impending or ongoing rupture. Better to go for laparoscopy or laparotomy. Clinically important abnormalities in baseline hematologic, renal, and hepatolaboratory values. Because methotrexate will worsen the situation. Immunodeficiency, active pulmonary peptic ulcer disease. Methotrexate is contraindicated. Hypersensitivity to methotrexate, obvious. Breastfeeding, again, methotrexate is contraindicated. What is the therapy consists of? Single dose of 50 milligrams per meter square or 1 milligram per kg or multiple dose protocol. Multiple dose only if it is not coming down even after 7 days. Factors that impact efficacy are high HCG concentration, need multiple dose, fetal cardiac activity, ideally it is contraindicated, but if you want to give, you should anticipate to give multiple doses. If it was large size, ideally you should not give methotrexate if it is more than 3 to 4 centimeters, but then some people want to try. Peritoneal fluid, that means again, it is controversial how much peritoneal fluid, maybe it is ruptured, whatever it is. Others, like if you have seen yolk sac, ischemic ectopic pregnancy, high folic acid, rate of rise of prior to methotrexate. So all these are some sort of factors that impact, and sometimes it is contraindicated or relatively contraindicated. Therapy follow-up. After 7 days, HCG is tested and then repeated weekly. If there is a more than 15% decline from days 7 to 14, check HCG weekly until the level is undetectable. Usually, as I said, it takes 30 to 35 days. If there is a less than 15% HCG decline from days 7 to 14, an additional dose should be given. If 3 weekly values are similar, an additional dose is given, maximum 3 doses. After that, you have to go for laparoscopy. If HCG is rising, TVS should be performed to see whether the ectopic is still growing, and you have to take appropriate action. If the HCG does not decline to 0, a new pregnancy should be excluded. And of course, immediately methotrexate should be stopped. While on methotrexate therapy, avoid vaginal intercourse or new conception until HCG is undetectable, obviously, otherwise it will kill the fetus or teratogenic. Pelvic examination during surveillance due to theoretical risk of rupture, I told you that. Even intercourse should be avoided. Sun exposure to limit the risk of methotrexate dermatitis, vitamin containing folic acid, otherwise it will negate the effect of methotrexate. Non-steroidal anti-inflammatory drugs also will hamper the methotrexate action, so it should be avoided. Outcomes, single dose was significantly less successful than laparoscopic salpingostomy. However, when additional doses were given in a single dose was unsuccessful, there was comparable efficacy. There was no significant difference between systemic methotrexate in a fixed multiple dose regime and surgery. So quality of life was significantly more severely impaired after methotrexate than salpingostomy. So you have to take a call case by case. Other outcomes, of course, tubal rupture was seen after methotrexate, so be careful, 31.9 per 100,000. Ovarian reserve does not, of course, appear to compromise. Fertility rate similar, I told you already about Cochrane review. And subsequent ectopic, same for both medical and surgical therapies. Surgery, all of you know, salpingostomy, salpingectomy, both can be done through laparoscopy or laparotomy, depending upon the skill. Small risk of retained trophoblastic tissue and an increased risk of recurrent ectopic pregnancy is always there in salpingostomy. That's why most of them don't do that now. Both procedures appear to result in similar subsequent fertility. And traditionally, salpingectomy has been the standard procedure, but salpingostomy is preferred because there is a conservative surgical option, which is again debatable, as I told you. Expectant management only for a small portion of patients with a very low risk for tubal rupture, and TVS does not show an extract interstitial sac nor demonstrates an extract mass suspicious of an ectopic. HCG is less than 200. Willing, able to post-treatment follow-up. This is a standard to dialogues. This is the same thing. Interstitial, of course, multiple doses required. Success rates are low, 66 to 100%. Finally, they'll end up in surgery. Mifepristone is not really very good. There's a new drug called gefitinib, but it requires a further study. Thank you very much for your patient listening.